All right, we can go ahead and begin. So welcome everyone to our shadowing session with Dr. Rodrigo Gerardo, who is a general surgery resident. Thank you so much for being here with us.
Yeah, thank you so much for having me. I'm glad to be able to help, and I know it's hard to get shadowing experience right now, and hopefully those things will be lifted soon as everyone's getting vaccinated, but I'm happy to do my part in the meantime. So thank you.
Yep, you can go ahead and begin.
All right, let me open up my share screen here. All right. Well, hi everyone. My name is Rod. I'm a general surgery resident. I'm a PGY3 at Wright State University in Dayton, Ohio. Currently doing my dedicated research years with Cincinnati Children's Hospital Medical Center in the pediatric surgery department. So today we're going to talk about general surgery as a career, me as a general surgery resident. I'll give you guys a few cases, and then we'll close it out with a little bit of a summary and question and answer. So me, again, my name is Rod. I'm from Cleveland, Ohio. I did my undergrad at University of Cincinnati, and then I went to medical school at Wright State University in Dayton, Ohio, and stuck around for general surgery training. So general surgery as a whole, I would say some things to keep in mind. It's not quite like the surgery residents that you see on TV, as much as I wish it were. Not everyone's a model. We have to wear sleeves at work and stuff like that. But there are three things that I think that people should know about going into general surgery residency. One is that I would argue that this is one of the specialties that deals with life and death more so, I think, than other specialties. And what I mean by that is, as the surgery resident we're dealing with, not only think of the severe trauma patient who comes in who is basically dying when they're coming into the hospital. Think of the surgical cancer patient who necessitates various surgeries for their cancer. And then at the same time, the flip side of that, life, because oftentimes I think of that trauma patient, you're pulling them from basically a situation where they were surely to die and saving their life right then and there instantly. Time, not just day to day, which is for residency 80, usually 60 to 80 hours a week, but also years, because general surgery residency is anywhere between 5 and 7 years, sometimes more. Subspecialty training can be 1 to 3 years or even more after that. Some surgeons do multiple fellowships, so they do multiple subspecialty training. So time is not just the day-to-day, but think of the years, think of the decades that go into that. And then the careers in general surgery. And what I mean by that is, from general surgery, you can do not only so many different subspecialties, but it's open to multiple different careers. As far as for me personally, I mean, that's public education through social media, but think of surgeons who have taken on, for example, the title of Surgeon General or hospital administration and things like that. I mean, there are a lot of different careers that you can go into in that regard. Why did I choose general surgery? I chose general surgery for two reasons. One is I was previously a musician. I used to play drums. So like in middle school, high school and stuff, I used to play drums. So for me, when I was a third year medical student, I got to actually, use my hands in the operating room. It felt more natural to me. It felt more satisfying to me to get to use my hands, similar to what I did when I was playing instruments. And then the other thing is I have a terrible attention span. So the instant gratification of surgery is a huge win for me. I love that a patient can come in with, some disease, they get a surgery, they go home. It's that instant gratification that I really enjoy. So for me, those are the two main reasons. So let's talk about a typical day for a surgery resident, a clinical surgery resident, not necessarily the research resident. So usually I would try to get to the hospital about 5 a.m. So I don't know what time that means for you guys to wake up and get ready. I live like 4 minutes from my hospital. So sometimes I would wake up like right before 5 and just go to the hospital. Then once you get there, you got to change, put your bags away, read up on the electronic medical record to see what's going on for the night, listen to whatever the night resident had to say about your patients, if anything happened, acute events or things like that. Any new patients came in the middle of the night they need to know about. I try to get that done within an hour. And then by 6 a.m., I do what's called pre-rounding. So that is when the resident walks around and wakes all these patients up at 6 a.m. before the attending sees them, just to lay eyes on them, make sure everything's okay, do a physical exam, and kind of see how they're doing, how their pain is, things like that. Then after about an hour of doing that and, going back and forth, checking on the chart on the computer, by 7 a.m., usually I'm trying to run the list with the rest of the team. What that means is if I'm on, for example, the trauma team, then I want to go through that list of patients that each of us were assigned specific patients. And we go through that list and we say, hey, here's patient so-and-so in room this. They had this surgery, they're post-op day 2 from this surgery. And here's my plan for today. And then usually the senior most resident will listen in and be like, okay, have a few questions and have a few ideas for the plan for the day. At most of my hospitals, usually 7 to 7:30 is when the first cases are starting. So that's when we start to go into the operating room. And usually if there are multiple residents on a team, then we divide it up based on complexity of the case, then which resident goes into each case, So then we're operating in the morning. Usually the junior residents, so the first or second year resident, holds the pager for the team, answers the phone, make sure if any orders go missed or anything like that they're taking care of that. Usually around noon is when the attending will want to eat lunch. So we get to eat lunch, and that's oftentimes another time where you get to run the list, maybe go check on a few patients with the attending this time. So actually round, depending on the service, that could vary. Sometimes that means, walking around with the whole team and checking in on every single patient with the attending. Sometimes that means maybe just the junior residents are running around while the senior residents are in the operating room. It kind of varies. And then in the afternoon, it's a mix of things. Some people are operating, some people are taking orders, getting new patients, writing notes, because patients don't stop coming in based on your schedule. So, and then by 6 p.m. is usually when you want to give sign out to the night resident. So oftentimes, our program, we use a night float type of format. So there's usually a resident who's designated to be there just at night to handle, new patients, consults, things like that. So you give sign out, meaning you tell them about all the patients, the important things to know, hand over the phone and things like that to them. And then after that, I usually try to make sure that everything is done for the day, finish up your notes. I don't like to do notes at home, so I try to do them all at the hospital and, try and get out of there at a reasonable hour. Then you hopefully eat something, sleep, and then wake up and do it all again the next day. So that's a typical day for me as a surgery resident. Before we get into the first case, or what do you think? Should I do some of these questions? There's a lot of questions coming in.
Yeah, you can do a couple questions right now if you want, or you can wait till the end. Totally up to you.
Yeah, I'll try to get a few of them done before we're going to these cases. So the first question here, what are the most common procedures in general surgery? What organs does this specialty involve? Most common procedures in general surgery are going to be the patients come in with acute cholecystitis, meaning their gallbladder is inflamed. So we do a cholecystectomy, meaning cutting out their gallbladder. Appendix in pediatric surgery, that's the most common surgery, is taking someone's appendix out. Hernia surgery, that's also one of the most common, that's probably the second most common surgery that general surgeons are doing. Then you got to think the organs that this involves is pretty much everything in the belly, almost everything in the chest. When you go to subspecialties like vascular and things like that, then you're talking about surgery on the extremities, so your arms and your legs. Now, general surgery could be a branch point to go into something like plastics. So you could end up operating on someone's face or their head and scalp. I would say, as a general surgeon, you're pretty much going to operate anywhere except for probably the brain, someone's brain or their eyeballs. So a lot of options, especially if you look at all the subspecialties that are available. Some common procedures in general surgeon. What do you think is the most important quality to be a surgeon? The most important quality to be a surgeon, I think that's going to vary depending on who you ask. For me, I want a surgeon. To me, a good surgeon is someone who not only knows how to operate well, but knows when not to operate, because we love operating, obviously, but to have the clinical knowledge to know when to say no. And what I mean by that is, the patient who maybe they're, 92 years old and it's not going to be worth it to do this big oncological resection on them because they might not live for another 5 years, tough decisions like that. What are some paths that you can take after completing general surgery? Is cardiac surgery or cardiothoracic surgery an option? Yes. There are so many things you could do from general surgery. You could do cardiothoracic, you could do vascular, pediatric, breast, surgical oncology, trauma surgery. There like so many things that you can do from general surgery. Why'd you pick surgical instead of non-surgical? So again, that was kind of like, I like using my hands. I like the instant gratification. How are surgeries conducted in general surgery different from surgeries in gastroenterology, especially ones that focus on the abdomen? Okay, so I think the biggest thing is gastroenterology is a procedural specialty. So they do things like scopes. If you guys have had GI docs come in and talk before, they do scopes. They go in through the mouth and down to the stomach and look at the small intestines, or they go in through the anus and look at the colon and things like that. But those are all like what I would define as like non-invasive natural orifice procedures. Surgery is like when we can do those things, sure, but if we're operating on a colon, if we're doing a surgery on a colon, then we're like going through the skin into the abdomen and doing surgery on a colon. So hopefully that makes sense, as opposed to, a colonoscopy. I guess some people call that surgery. Have you ever used any AI technology during any general surgery procedures? Do you think a fellowship would be beneficial to take when pursuing general surgery, and which specifically? I have not used AI, but I know that it's growing. I can't really comment on. I don't think it's mainstream yet, but it's definitely something that a lot of people are researching. Let's see here. Wow, you guys got like so many questions. All right, I'll stop there and then we'll go on with the case. All right, so you see this little kid coming in, this little boy, he's a 9-year-old male. He's got acute onset right upper quadrant pain. You do a history and you're like, oh, well, this pain's pretty bad. It's 8 out of 10. It started maybe about, 8 hours ago. It started as umbilicus, that means his belly button. And then it moved down to his right lower quadrant. That's what RLQ stands for. And then when you do an abdominal exam, so you push on his belly, that's pretty much what we're trained to do. And when you do that, it really hurts on his right lower quadrant. And when you push on his left lower quadrant, it makes it hurt in his right lower quadrant. That's kind of odd. You look at his vital signs, they're all basically normal. So when you see a patient like this, you get the history, you get the physical. That's usually the first thing you do. You look at their vitals, make sure that they're not crashing. You know what I mean? And then you start to think of your differential diagnosis. Now, in general surgery, because we're operating in the belly a lot, what I like to think about is anatomically, what is there? Where's the pain? And what's under the skin there that would cause that pain? So, for example, this little kid, his pain is in his right lower quadrant. So that's that blue square there. So really common is appendicitis. If he were a female, then you would start to think about other things, gynecological things, Similarly, if let's say his pain was on the opposite side, that green box in the left upper quadrant, well, the stomach is right there. So then you got to think of things like gastric ulcers, So for me, the first thing is when you're making a differential diagnosis, think about what's there and what are the common things that are going to cause an issue in that area. So for this patient, the next thing you do, so now you're thinking in your head, Could this kid have appendicitis? So the first thing you're going to do is you're going to get some imaging and some lab work. So in kids, that's going to mean an ultrasound. So you get an ultrasound, you look at this and you say, oh, well, look at that. His appendix is pretty dilated. It's pretty big. And then you get some blood work and you see, well, his white blood cell count is a little elevated. That's your immune system cells, right? So then there's something going on that's making his immune system go up and activated, and his appendix is kind of big for some reason. So now we're starting to think more and more, okay, maybe this is what we call appendicitis or inflammation of his appendix. Well, what do we do for that? As surgeons, we cut it out. And in 2021, that means a minimally invasive or a laparoscopic appendectomy. So that means we go in with tiny little tools, tiny little camera, 3 incisions that are in a kid, 0.5 millimeter to 1 millimeter long incisions into the skin. We put these little tools in and we take the appendix out. Now, if you guys have taken anatomy class, then the appendix is that little worm-like structure that hangs off the first part of the colon. So this middle picture is a laparoscopic surgery. It's not an appendectomy, but that's someone doing a laparoscopic procedure. So you can kind of see what it looks like there. And then here is a view of a laparoscopic view of an appendix that's a little bit angry. You can see the blood vessels are all dilated. It's kind of thick and it looks like a worm. So what we do is we go in with these tiny little tools. They're like little chopsticks with teeth, and we grab it and then we kind of snip it off. Now, if just to recap, so like I said previously, in pediatric surgery, the appendectomy is the most common surgery that pediatric surgeons are doing. So if a kid comes in with right lower quadrant pain, I mean, that's what you're going to want to think. That's the first thing that I would think. But obviously, you want to keep a broad differential. You don't want to miss anything if it's not. Now, we got an ultrasound on this kid. And we did that because in kids, I don't know if you guys have had a radiologist or anyone on, but, in kids, we try to decrease the amount of radiation exposure that we're giving them. So an ultrasound doesn't do any radiation. Those are just sound waves. So if this were an adult, they probably would have gotten a CAT scan, specifically a CAT scan of their abdomen and their pelvis to try and find what's going on in that region. And then another controversial thing to think about is antibiotics or not. Antibiotics and NOT, which is non-operative therapy. So some studies are starting to come out now in adults and kids that suggest that, hey, maybe we don't have to take out every single appendix that comes in the door. Some patients seem to do well with just getting antibiotics and going home, and then their appendicitis goes away. This is a picture of what a CAT scan looks like, AKA the donut of truth. So the patient lays down on that bed and then they go through the CT scanner and it gets a whole bunch of images. I like to think of it as like getting slices of bread. So when you look at the image, it's basically getting multiple, almost like x-rays along the person's body. And then when you look at those x-rays, it's like you're taking out a slice of bread, one of those pieces of bread, and looking at it and trying to see what is going on, almost like a cross section. Okay. Now, this is the ultrasound. If you guys are in physics class, like every good pre-med is, then you probably remember that the ultrasound, the way it works is that it sends out sound waves, vibrations and sound waves. Those hit something that has a specific density that would reflect those waves back. And then it tells you kind of like how dense that object is. And then based on that, it puts it on a gray scale. So that's how you see black, white. So things that are, like that sound waves go through really easily, like air is going to be black. Water is going to be black. But then other stuff that's thick, like your organs and stuff, those are going to be kind of grayish or white. All right. Case number 2. So we're hanging out in the doctor's lounge and, you're eating your ice cream, relaxing in the middle of the night, and suddenly your pager goes off. And your pager reads this in the bottom right-hand corner. 25, I'll decipher this because oftentimes in medicine, we use a lot of, acronyms. And I'll be honest, I didn't know what any of this stuff meant when I was a pre-med. So 25-year-old male, category 1 trauma. So it's telling you the severity, right upper extremity, gunshot wound. And then it's going to give you vitals. The heart rate is 120. Hint, hint, that's a little bit fast. The blood pressure is 100/60. That's borderline low. It could be normal for a 24-year-old, but the lower number, the diastolic number, is pretty low at 60. So that'd be concerning. The oxygen saturation is at 98% on 2 liters nasal cannula, meaning those little tubes of oxygen that they put in their nostrils to put air up there. And there's a tourniquet in place because there's a gunshot wound to the right upper extremity. Well, so now we know that this patient has a gunshot wound in their arm. They probably bled enough that their heart rate is kind of up, and they're bleeding enough that the EMS had to put a tourniquet there. So like wrap it around and then stop the bleeding. So we're going to put our ice cream down. We're going to run to the trauma bay. Now, this is what the trauma bay usually looks like at first. So you have a huge team. Everyone's wearing their PPE, and the EMS, these guys in the gray, they'll bring the patient in on a board, and we'll transfer the patient onto the hospital bed, and then we do what's called the ABCs of trauma. So if you guys know what the ABCs of trauma are, then type them in the comment here. But that's the first assessment that we do. The primary survey is what we call it in trauma. So what does that mean? A is airway, meaning the path from their mouth down to their throat, to their trachea, down into their lungs. That pathway, is it patent, or is it open, or is it compromised? If it is, then do you have to intubate, meaning putting a breathing tube in? And then that whole time you got to protect their cervical spine, so the bones in their neck. Let's say this patient was shot, so it would be less of a concern. But if they were in a car crash or they fell from a height, you don't want to be moving their neck and looking at their airway, because you might worry if there's broken bones in their neck, ligamentous injuries, because then if that caused any issues with their spinal cord, then they could be paralyzed. So you have to be this with that. This guy probably don't have to as much. Breathing. So then once the airway is intact, are the lungs getting enough air? And we do that by getting an old-fashioned stethoscope and listening to their lungs. Circulation. So we got a little bit of this information with the vitals, but basically we're looking at their heart rate, their blood pressure. We're going to get IV access so we can give them fluids, because if they're losing blood, then we got to give them either saline or blood. And then hemorrhage control. In this case, it was a tourniquet. So they put a tourniquet on the arm, they tied it up, and they stopped the bleeding there. But there must be some vessel that is compromised that they had to do that. So ABC, and then D, disability. So we do this by getting a rough neurological exam called a Glasgow Coma scale. It's based on their eye movements, their verbal, and then their motion that they're able to do. This gives you a rough prognostic indicator of how they're going to do based on a really quick neuro exam. And then environment. So we had to remove the clothing from this patient to really examine everywhere. Yes, he has a bullet hole in his arm, but how do you know he didn't get shot multiple times? You don't. So we're going to take off the pants. We're going to take off the shirt, make sure that they don't have bullet holes in their back, make sure that they don't have any bullet holes on their chest or their stomach that we missed, or anything in the legs. Could they be bleeding somewhere else from somewhere that we don't want to miss that, basically. All right, so you get down there. The airway's intact. He's yelling. He's screaming. My arm is killing me. And, he's able to move everything. And then you're like, all right, so he's doing okay from everything else except for this gunshot wound. You look at the arm, you clean off the blood and everything. You take a look, and he's got this big gunshot wound in his arm. You think, okay, well, it looks okay. Let's take off the tourniquet. Well, then there's blood everywhere, okay? So you get blood all over the floor. Good job. And then the blood is pulsatile, so it's spraying at you, and then it hits the wall behind you, and it hits your intern in the face. Good job. So let's put the tourniquet back up. You got blood all over the place. There's some sort of arterial bleeding. It's this bright red pulsatile blood shooting back at you. So what do you do next? Well, I'm a surgeon. This is a surgeon talk. So guess what? We're going to go to the operating room. So specifically for the arm, if you guys have taken anatomy, then you guys know you got some important blood vessels in the arm. If you guys are in the comments, type in what you think it is. But I mean, the main thought is you have a lot of named vessels in your extremities that if they are damaged, you could lose a significant amount of blood very quickly, depending on how that injury looks. And especially in someone who's young, who has really good blood pressure and he's pumping blood out like this, who knows how long they were laying there. They could lose a significant amount of blood and they could die from that. All right, so we go to the OR and we cut open the arm. Now, this is like a cadaver thing, and it looks like a vascular dissection because everything's all neat and pretty. This is not what it would look like in trauma. But under the biceps there, the medial aspect, you're going to see the brachial artery, that big, thick boy right there. So let's say, hypothetically, this guy, the bullet severed his brachial artery. So you have a few options. If you can cut the surface to make it a nice clean cut and sew it back together and there's no tension, you could do that. If you have to do a bypass, you could do that. We do bypasses with, what we do is we get veins. Oftentimes from the legs, we get a big, the greater saphenous vein. You can take a piece of it and use that as a, what we call a conduit. So think of it like plumbing. There's a piece of the brachial artery that's broken. So we're going to take a piece of vein and put it in there to bridge that gap. Or you could use PTFE, which is kind of like, it's kind of like Kevlar, essentially, a tube, a plastic like tube. So you have a lot of options, but in this guy, you find it and you save him. All right, how are we doing with time here? 9:30. Awesome. All right, let's do case number 3 here. So we did a pediatric surgery case. We did a trauma case. Now this last one we'll do is a little bit different. So this one is you're in clinic and this guy comes in, the 65-year-old guy comes in and he says, "Hey doc, I got some blood in my poop." So think to yourself, what are some questions that you would want to ask? What would you, let's say I'm busy and I'm, trying to catch up on notes from clinic. Type in the comments here, what do you guys think that you would ask this guy if you sat down and talked to him in clinic? So it's not urgent. He's not dying in front of you. He's just here because he had a question because he saw some blood in his poop. All right. So what would you guys ask him? All right. And then here's what I got from him. So he's a real nice dude. He's not in acute distress. That's what NAD stands for. No acute distress. And he says, "Hey, look, I had some blood in my poop for about 3 months. It comes and it goes. It's a lot. It's a little. I don't have any pain in my belly. It never happened before." And then, like, okay, well, let's do an exam. So you do, you listen to his heart, nothing. Heart, regular rate rhythm. No murmurs, rubs, or gallops. You listen to his lungs, clear to auscultation bilaterally, meaning that they sound normal. Excuse me. And then you got to push on his belly because that's what we do as general surgeons. You push on his belly and it's soft, so non-tender to palpation, and all of his vital signs are within normal limits. So it's pretty much like a negative abdominal exam, heart, lungs. Now, because he has blood in his stool, then the next thing that you are kind of inclined to do is a rectal exam. So you do a rectal exam, you don't see any gross blood. Now, you guys probably think that any blood from the rectum is going to be gross, but what that means is like visible blood. And then you could put that on a hemocult, so a piece of paper that tells you with a chemical test whether or not they're like microscopic blood in the stool, but his is fine. So then you got to ask some other questions. Family history. Anyone else in the family have any problems with their colon or their butt? Anus, I guess, or rectum, you should say the medical words. This guy's 65. Has he had a colonoscopy? Let me know in the comments what you guys think. What age is this guy supposed to get a colonoscopy, a screening colonoscopy? And then you got to ask about some other stuff. Constipation, diarrhea, details as far as the blood in his poop. I mean, is it mixed in or is it right after he poops and he wipes with the toilet paper, there's blood? Because those kind of have some differences. Is it bright red blood or is it maroon colored blood? Is it black and tarry stool? These are the details that you want to get into. And then what do you want to do next? Well, kind of spoiled it here, but for this guy, the next thing to do is probably to, we should come up with a differential first. I'm getting ahead of myself here. So differential diagnosis for blood in the stool. So common things that are quote unquote benign: anal fissures, meaning a tear in the anus, in the anoderm, the skin around the anus. That happens when people are constipated, and then over time they have a really large formed hard stool, and then because of the diameter, then it tears the anus. That's a really common reason for people to get blood in their stool, but that's at the end of the stool. That's when they're wiping. Hemorrhoids, so those are venous, kind of like venous dilations of vessels that are in the anus and the rectum, and they can get very large, and they can sometimes protrude out of the anus even, and oftentimes they can bleed. AVM, arteriovenous malformations. These are these kind of like spiderweb looking malformations of blood vessels that can be found throughout the colon. And then diverticulitis. This is, so you see on this image here how there are like these little, almost like these indentations that you see there. So those are called haustra. Oftentimes those are they're little weak points there, and they're arteries that go through. And if sometimes patients over time, if they're really constipated and things like that, then there's a lot of pressure there. And then those little weak points can herniate out, and you get a little outpouching called a diverticula. Those things can get infected, they can bleed, things like that. Now, in the back of your mind, when a patient who's, 65 coming in with blood in their stool, in the back of your mind, you also have to consider, does this patient have colon cancer? Okay. So what are we going to do next? Spoiler alert, we said it before, we're going to give this guy a colonoscopy. So the current recommendations in the United States are patients who are 50 to 75 years old should get their screening colonoscopy. So I would say everybody pretty much at 50 should get a screening colonoscopy. Those recommendations are possibly in the process of changing. There's some recommendations that we go even younger at 45. That's not hard, fast rule yet. And then you got to consider if there's family history or anything. Then sometimes if there's a family history of certain genetic cancers, then patients should get screened earlier than 50. All right, so you do the colonoscopy on this guy. You put the scope in. We as general surgeons can do colonoscopies. I actually have to do them to graduate from residency. So you do the colonoscopy, and then you go in, you find this giant mass. Well, what do? Well, you take a biopsy of it, you send it to the pathologist, they look at it under a microscope. And then they come back and the pathologist calls you and says, hey, Rod, this guy's got adenocarcinoma. He's got colon cancer at his sigmoid colon where that mass was. It's bad. So one of my mentors, who's a surgical oncologist, says, with cancer, what we do is surgeons, you name it, you stage it, and then you treat it. So this is the first part. You name it. That's the diagnosis. This one is named adenocarcinoma. Then you have to stage it, meaning we have to figure out basically how bad this cancer is. So for the staging criteria, it varies based on the cancer, but in general, you're looking at what we call the TNM staging. T for the tumor, so how big is it? How bad is it? N for lymph nodes. So has this invaded lymph nodes, like moved out of the tumor into a lymph node and infected those lymph nodes now? And then M for metastases, meaning has it gone and grown somewhere in some other organ system somewhere else? So to do this, we're going to get some lab work, we're going to get blood work, we're going to get a CAT scan of the chest, abdomen, pelvis to see if there are any metastases. We're going to get a CEA level, that is a tumor marker for colon cancer. And then depending on where the tumor is, you can get an MRI in the pelvis, especially if it's really distal sigmoid or in the rectum, because it's hard on CAT scan sometimes to really see in the pelvis those details. So you can get an MRI. There we go. So we named it, we staged it. For this guy, it was T3, meaning it had a thickness of how far it went. There's no lymph nodes and there's no metastases. So now we're going to treat it. Now this patient, if they have sigmoid cancer, that's going to be that bottom part there, that S. So what we do is we do what we call a laparoscopic sigmoidectomy. We go in with those chopsticks like we did for the appendectomy. We go in with a bunch of those and we cut out this piece of cancer. And then you got to take the blood supply with it. So we cut those sigmoidal arteries with it. And then these patients will oftentimes may get adjuvant chemotherapy, meaning they get chemotherapy after surgery. Oh, that was the end. So there we go. So we named it, we staged it, and we treated it. So those are 3 potential cases for a general surgery resident. But like I said, this could have gone on for days. We could have done a vascular case. We could have done a breast case. We could have done, a bariatric case. There are so many different options with general surgery. So those are just 3 common scenarios that I picked. And then I put here my social media handles if you guys want to find me somewhere else. And then let's see here. I guess we could get back to some of these questions. Holy crap, you guys got a lot of questions. Okay. Let's see here. Where did I leave off? Okay. After completion of residency, what is the procedure like to specialize in the subdiscipline? So I mentioned that you could pretty much go into all sorts of different things. What are some of the hardest procedures you perform? Hardest? I don't know. That's kind of relative. I would say, let's unpack that word. Hardest as in like complex, difficult. I mean, I think for the first one that comes to mind to me is a procedure like a Whipple. So if you guys Google Whipple, Whipple, it's a pancreatico duodenectomy, duodenopancreatectomy, something like that. You cut out the pancreas, you cut out the duodenum. It's for pancreatic cancer. That's one of the more complex surgeries. But I mean, there are a lot of complex surgeries that we do in the abdomen. I mean, you can look at liver transplants. You can look at actually any transplant surgery, really. There are a lot of different, a lot of different ones. Everything's hard for me because I'm a surgery resident and I'm only a 3rd year. So there's that. How has training for general surgery changed since more and more surgeries are becoming less invasive? More and more surgeries are becoming less invasive. That is how it's happening. What we're finding is, these big open belly surgeries that we're doing might not be the best for patients. They do oftentimes do better with minimally invasive surgeries, with tiny laparoscopic surgeries. They get out of the hospital faster. They're eating faster. They recover faster, things like that. Is general surgery training longer or harder since they require more holistic knowledge of all body systems? And what is your favorite surgery to perform and why? Okay. Is it longer and harder since no, general surgery training is 5 to 7 years. It's always been 5 to 7 years. So it's not changing or anything like that. I think that people are shifting the focus of what's important and trying to make more holistic surgeons, but the number of years isn't changing. What's your favorite surgery to perform and why? Mine is a carotid endarterectomy. So that's when patient has blockages in the carotid artery. There's about 10% of strokes occur because of blockages in the carotid artery. So what we do is to prevent strokes is we go in and we open up the carotid artery and cut out all those boogers, all that calcified plaque. It's super rewarding. I really enjoy it. All right. What does the operation look like during surgery? Is it very chill or stressful in general? So the operation room looks like, if you guys Google it, that's it. It's, you can find pictures online, and I showed that picture. Where was it? In the appendectomy case here. So that's kind of what part of what an operating room looks like. Everyone wears these blue sterile paper things. Is it chill or stressful? That depends on the situation. It depends on the attending surgeon who's in there. It depends on what's happening. What does a day on the job generally look like? What are the greatest obstacles you have, procedures? What are the factors that affect each surgery? The general job day is kind of like that other slide that I had. So if you guys missed it, so that was this one. For me as a surgery resident, it's basically in the hospital from 5 a.m. to 6 or 7 at night, pre-rounding, rounding, going to the OR, taking care of, new patients, consults, things like that. What are the greatest obstacles you have with procedures? That depends on the procedure. I mean, every procedure has its pitfalls and its issues. What fields are needed for mastery in order to pursue general surgery? I think a general blanket statement for it, no matter what you want to go into, it takes a passion to learn about that specialty, whether it's surgery, internal medicine, pediatrics, whatever it is, to master it. It's like that Malcolm Gladwell thing. It's like 10,000 hours. You have to be willing to put in the time and the work. In surgery, what that means not only learning the physiology and everything, but learning, the actual surgeries and learning how to use your hands and learning the techniques and things like that. Have you ever used any AR technology with 3D cameras and such during general surgery procedures? What do you think? Oh, wait, I saw that one. Yeah, I haven't. I can't really comment on that. I know that some people are. What was the most interesting surgery you've performed as a resident? I mean, I really like vascular surgery, so that's always fun for me. A lot of vascular surgery is now like endovascular. We can do a lot of things with wires, basically. So complex vascular surgeries are really interesting to me. Let's see here. Do you have to go through residency for a long period of time to have a comprehensive understanding? Like I said, 5 to 7 years. It's always been like that. Have COVID decreased the amount of patients you get? Sort of. So during the peak spikes of COVID, a lot of elective surgeries were canceled, meaning surgeries that, the patient is going to die if we do this surgery. Think of like a hernia that someone's had for a decade or something. They're not going to necessarily die right then and there if you don't do that surgery. So some of those were decreased, yes, but overall, I would say, I guess I would have to look into the data. I actually don't know if overall surgeries have decreased or not. What systems do you work with in general surgery? Pretty much everywhere, guys. Everything in the belly, anything in the chest, heart, lungs. Like I said previously, I think the only things that we don't really operate on are like the brain, your eyeballs, I guess things in your ears and stuff like that. Bones, that's orthopedic surgery. I mean, pretty much any organ system is fair game in general surgery. What was the most interesting case, and what cases do you work with? Yeah, like I said, I mean, I love the complex vascular surgery cases. Cases do you work with other specialists? So, I mean, oftentimes with, let's say, a cancer patient, we'll do an oncologic resection, meaning we're cutting out cancer, and then a plastic surgeon will come in and, try and make that area look better. I'll tell you one case I was in. I remember it was a patient who had a sarcoma, soft tissue tumor that was invading into her femur. So it was a surgical oncologist to cut out the tumor, make sure we had good resection. There was a vascular surgeon to make sure that the blood supply was preserved, or whatever blood supply was there, we could preserve so that the rest of the foot was getting blood. There was an orthopedic surgeon for the bone aspect of it, for the resection of the bone. There was a plastic surgeon for the flap, or the muscle flap that goes over. So there are surgeries that are really complex that have a whole bunch of different specialists in them. Let's see here. Most common procedure you perform in general surgery, how's code effectively work? So like I said, the most common procedure for general surgery, it's going to be appendectomies, it's going to be cholecystectomies, it's going to be hernia repairs, trauma, things like that. When do you learn how to perform surgery in college? You don't. You learn how to perform surgery in surgery residency. Don't get too anxious there, guys. Let's see here. Some really great responses from the questions that I was posing here throughout the cases. Are there any type of specializations that you do not often work with? Okay, so specialties we don't often work with. I don't know. I guess that's tough, because so let me put it to you this way. Let's say we're on trauma surgery, I consult like everybody in the hospital. I feel like, I mean, I'll have patients who, a patient who gets into a car accident, they might be suicidal, so we're consulting psych. They might be pregnant, so we're consulting OB. They might have a previous heart condition that now is exacerbated because they're in the ICU, so we're calling cardiology. They might have lung problems, so maybe we have to have a pulmonologist on board. I mean, I feel like as a general surgeon, you're dealing with so many different organ systems. You're going to call pretty much everyone. I don't know if there are people I don't call, honestly. Even like PM&R. So then you tee up the trauma patients to go home. They have to have PM&R when they go home. I mean, I feel like we call everyone because we operate all over the place. Do you have to memorize the procedures for hour-long surgeries? I mean, I guess you should. If you're going to do a surgery, you should be comfortable with it. To me, that means that you know the ins and outs of the surgery, you know the anatomy that's pertinent to that surgery, you know how to do it forwards and backwards, and you know the pitfalls to expect, the aberrant anomalies in anatomy to expect, things like that. So do you have to memorize the procedures? I mean, I guess so. I don't know if a surgeon would take a patient to surgery if they didn't know how to do that surgery by heart. Because I mean, I don't know. What are you gonna do? Google it in the middle of it? You know what I'm saying? So I don't know. If you're not comfortable doing a surgery, then you just say that. I've had attendings before who are like, oh, I do this kind of surgery and not this kind of surgery. I'm going to refer you to someone in town who does that, and they do it all the time, because that's what it comes down to, is you want to be, to get good results. I mean, you have to do that surgery often and do it well. So, I wanted to make sure I got through all those questions.
Yep. Yeah, I think that's the last question. Thank you so much. That was actually really great. I definitely learned a lot about like just like your day in the life and like different types of cases that you encountered. That was really interesting. Love the pictures, by the way. And yeah, I think this definitely kind of nudged me towards general surgery or surgery in general.
Yeah,
But yeah, so thank you so much. We really appreciate having you today.
my pleasure. Thank you guys. If you do like surgery, great. Feel free to shoot me a DM. I can be as helpful as I can, I guess. But if you don't like surgery, that's fine. I think a lot of people, surgery is not for them. And I think that just at least having an understanding of other specialties and what our colleagues are doing, I think is important, because you're going to work with, no matter what you guys are going to end up going into, you're going to work with a surgeon sometime down the road. You're going to call a surgeon about a patient, have a mutual patient down the road, and you have to talk to them. And it's worthwhile to kind of understand what each other is going through. Or at least
Mhm.
that's what I try to tell myself when I'm, talking to a psych resident or something like that. So good luck to you guys. And yeah, follow me on TikTok.
Yep, of course. And also for everyone who's still watching, the Google Forms will close at 10:20. So be sure to fill that out.